computer. Okay, cool. So Continuum is a journal that is really tailored to teaching residents in neurology. So it's like a go-to journal that a lot of residency programs kind of recommend. And a lot of these articles are PubMed indexed. So for example, if you wanted to look up this article, you could just type in the author's name, Continuum, and the year it was published, and you'll be able to find it. So it's really good for just like walking you through different topics of neurology. And the cool thing about this is that they have different issues corresponding to different topics. If my internet wants to cooperate, they have different issues that correspond to like the big topics in neurology. So they have, for example, they have a new one that just came out, Neurology of Pregnancy. They have an entire journal dedicated to epilepsy, spinal cords, neuro otology, headaches. And so if you read through this, for those who are residents or those, who are going to be residents soon, then you have a good like overview of, okay, these are things I need to know for these specific topic regions. And they put one out every 3 months. And then in order to stay up to date, for example, they did epilepsy. Maybe they did epilepsy 4 years ago. So every 3 years they do the same topic so that they're teaching us very up-to-date information. So yeah, look into it. And some schools have subscriptions to the journals. So just take a look and see what your school has access to. So I love it. And then I could be when I'm on round. Just mute everybody. When I'm on rounds, I can say, well, this article by Hardy and al. Says that headache is this, and this is how you can treat it. And they're like, oh, okay, well, can't argue with you there because, so it's really cool to be like, evidence-based. And like Dr. Akitukuman said, important to have 1 to 2 sources that's your go-to. So yeah, so this is a really great source for neurology. And I'm sure as we do our study groups, we can come up with sources that's like evidence-based, reliable, that you could use, when you're working through cases. So this here just kind of talks about, spinal cord anatomy, localization. And so for the medical students in the study group, I think the big thing for step 1 and step 2, I think more so step 1 is knowing that pathway. And so we can kind of talk about, so this article, they talk about, like the overall anatomy of the spinal cord. So you guys know that I like to be interactive. So how many, and you can use this to answer the question, what are the big components of the spinal cord? Major components of the spinal cord. The hint is it's in figure 1.
Are you talking about the segments like cervical, thoracic, and lumbar?
Yeah, exactly. Yep. So cervical, thoracic, lumbar. A good thing to know is like how many cervical regions are there, how many thoracic, how many lumbar, how many sacral. So in this article, they give the number, and I just want to make sure that I say it right. So I believe that there's, okay, we see it here. So there is 7 cervical vertebra. There are 12 thoracic vertebra. There are 5 lumbar. So 7, 12, 5. And then there are also 5 sacral. And on neuroimaging, the sacral, they're really fused. So you really won't be able to see the sacral vertebra on the spinal imaging for the most part, especially when you're looking at the more anterior view. But just know, if someone says, oh, give me, what's the spinal cord? You got cervical, thoracic, lumbar, sacral. You got 7, 12, 5, 5. And I think there's some mnemonic to remember it. I can't remember off the top of my head, but that's the mnemonic. And when they talk about nerves, although there's 7 cerebral vertebra, there's 8 cervical spinal nerves. There's 12 thoracic spinal nerves. There's 5 lumbar, and there's 3 sacral. And so you just have to commit this to memory. There's a mnemonic to remember it. Oh, okay. Dr. Akatutomen says she uses, Addie, how do you say that? The book you use.
Nelly.
Nelly.
The idea being that I think it's helpful to have like one core textbook as your source. Everyone's going to say in your specialty, this is your go-to resource, but then like it can be boring sometimes to read from a textbook every day. So then I also I'm a audio learner. So, and I like to watch videos. So this other podcast, EM Rep, has monthly podcasts, and then also like really instructional procedural videos that like if something comes up, usually on shift, that I just want a quick reminder about, I can just quickly read on that podcast, or look it up on that podcast and get the information I need. So having like 1 or 2 sources, it's tempting to use everything, but then you won't read everything. You won't read all of everything. So pick your 1 or 2 and stick with them.
And maybe we can have a study group like focus on, resources out there, because I do a lot of podcasts and YouTube videos, and there's people that I follow. And some of the people in the group actually produce like infographics. And so we can just talk about, some of those high yield evidence-based resources that are good, for neurology and for other specialties. Okie dokie. So we talked about what will come up for the medical students is that they like to talk, and Addie and I talked about this yesterday. They like to talk about cauda conus medullaris and cauda equina syndrome. They love talking about those 2 syndromes. So know that the conus medullaris is this part right here, the tail end of the spinal cord, which ends at L1, L2. And that's why when you do a lumbar puncture, you do it at L3, L4, because you're nowhere near the spinal cord. So they love to talk about the conus medullaris. So just know that that's where that is. And they also love to talk about the cauda equina syndrome. And if we have time, we'll get into, the difference of conus medullaris and cauda equina. And I think Dr. Akatutomen will be doing a, L3, L4, L5, acute spinal cord alive. So that's a good mnemonic when you're doing an lumbar puncture, like, I don't know what level to go. Just remember this: L3, 4, 5, acute spinal cord alive. So if you go to those levels or below, you are not going to hit their spinal cord. Cool. Awesome. If anyone has anything to add, just feel free to chime in. So now we kind of know the overall anatomy of the spinal cord. It's really good to know your tracts. There are sensory tracts, and then there are motor tracts. Big sensory tracts to know. Who can tell me? And you can use this figure 1.2 to give you a hint. What spinal tract is responsible for vibration and proprioception?
The dorsal column.
Yeah, dorsal columns. Yep. And then what spinal cord tract is responsible for pain and temperature?
Spinothalamic.
Yep. And so you have like the anterior spinothalamic and lateral spinothalamic, but the spinothalamic tract is responsible for pain and temp, and dorsal columns is responsible for vibration, proprioception, and I believe pressure. Fantastic. What are some of the other cords? What cord is responsible for motor, like main motor functioning?
You have the
What was that?
Corticospinal tract.
Exactly. Very good. So I'll highlight some stuff here. So as was said, posterior column. Yeah, this is high yield. Step 1, step 2, especially because if I'm learning anatomy. You have to know your anatomy, because once you know your anatomy, it'll help in neurology. How we like to talk about clinical diagnosis is, we get our history, we get the chief complaint, get the history, we do the exam. First question they're going to ask you when you present a case, is this neurological? Yes or no? And if you say yes, where does it localize? So in order to know how to localize, you got to know what your anatomy is. And then based on your localization, you can then know, okay, localize it to the spinal cord because of these reasons. My differential is this. So knowing anatomy is very key. And so, yes, so we have the dorsal column system. And within dorsal columns, you have the gracilis fasciculus and cuneate fasciculus. Does anybody remember which one is arm?
I believe that's the cuneate fasciculus is arm, and then the gracil fasciculus is legs.
Yeah, and how I remember it is that the innermost, so you start from the bottom and you go up. So the innermost is going to be the lower extremities, because those fibers will come in first, and those fibers are going up, going up, going up, and then when you hit the thoracic enlargement or the cervical enlargement for the arms, that's when your cuneate comes in. So I remember the innermost is for legs and the outermost is for the arms. Fantastic. So if you knock out the dorsal columns, what are your symptoms going to be?
Sensory problems, proprioception deficits.
Yeah, exactly. Yeah, very good. And how do you test for proprioception?
Do you use the big toe and kind of
Yeah,
identify, like ask them, are we up, are we down? Like, first show them with their eyes open and then do that same exam with their eyes closed to see if it matches, or?
yeah. So you're close. So for proprioception, if you want to test true proprioception, you have them close their eyes, right? And then you can do the digits. You take, their finger, make sure you hold actually at the joint, hold it at the side, because I see a lot of students do this. If you do this, then you are inducing, like if you hold it like this, and then you tell them move up or down, you're pushing their finger so they can sense your pressure. So it's going to be hard to really assess for proprioception if you hold the finger like this, like top to bottom. So you want to hold it on the side so that they're not getting that pressure sense. And then you want to, if I had another finger, I would isolate this joint here with one finger, and then the other finger, move it up and down. And you just want to do just slight movements, very slight. You don't, you just want to do, and you can do it on, maybe 2 fingers here, 2 fingers here, toes, doesn't matter what toe you do for the most part. And then that's how you can sense proprioception. So let's say that they are not able to get it here. Well, then you want to see when can they get it? So you do, the most distal joints, and if they miss it, then you can go to, the MCP joint here and just do like, if they miss it, then you can do the wrist and then see if they ever get it right. I've done that. And there's 2 symptoms, like 2 etiologies that come to mind for like textbook proprioception is vitamin B12 deficiency and neurosyphilis.
Yeah, the tertiary syphilis. And
yeah, so those are especially B12. B12 is high yield on your step exam. So know that it's what's subacute degeneration. Is that right?
yes.
Subacute combined degeneration.
Yes.
Okay, that's high
correct.
yield. Cool. So I think we've talked proprioception, and then we did vibration, and I love my Neuro Tools. Do I have my Neuro Tools? I'm gonna go get my Neuro Tools. Oh, I can't find it. Okay.
Yeah. What do you put in your toolbox?
Everyone. Okay, let me get it. Since you asked, let me get it.
Everyone has their toolbox, so.
Okay, so I am like a nerd at heart, and yes, I'm bringing back the fanny pack. I don't care what nobody says.
No, that's in style. That is in style. Yes, I'm telling you. It's
too kind to me, but I'm bringing it back. I don't care what nobody says. I'm bringing back the fanny pack because this is where all my tools are. So For vibration, you know, you want to get the 128C. You can get this on Amazon, 128. You know, it's standard in neurology. So I don't know how much it is on Amazon. You can get it anywhere as long as it says 128C, because if you get anything smaller or larger, you know, it's not going to be what neurologists are using. And then for vibration, you do similar in that the distal joint, tell them to close their eyes, you know, use your hand to do the vibration, and then you put it on their finger, and then you just ask, do you feel it? Yes, no. And then you can get fancy. You can like stop it up here while still on their finger, ask them, do you feel it? Tell me when it stops. Sometimes what some people do is to let it vibrate the entire time. And then you ask them, tell me when you feel it stop vibrating. But I think to keep it simple, you hit it, vibrate, ask them, do you feel it? Yes, no. And then you go to their other hand, feel it? Yes, no. You do the same with the toes. You feel it? Yes, no. If they say no, then you work your way up until they feel it. So for the hand, if they don't feel it here at the fingers, and they don't feel it at one finger, you know, try another finger. And if they still don't feel it, okay, go up to their MCP, then their wrist, then the elbow, because the attending's going to ask, okay, so they had decreased vibration to what point? And if you can say, oh, well, they had it up to the ankle or they had it up to the knee, it gives you insight into the pathology. So that is vibration, talking about proprioception, and pressure. We really don't test pressure. Cool. So now let's talk about the anterior lateral system. The biggest thing to know for now is the spinal thalamic tract. So you're going to have an anterior portion, and you're going to have a lateral portion. Let me see if they note it here. Do you guys see it? Because I don't. Okay. So here's the lateral portion.
Did they combine it? It says anterior lateral.
Oh, yeah. So maybe they're calling this like the anterior part. Let me just erase. So this is what we're talking about now. So maybe they're calling this the anterior part and this the lateral. Sorry, this anterior, this lateral. So like someone mentioned, you have pain and temperature here. Can someone tell me, I wonder if they talked about this. What is, oh, we didn't talk about how it travels. Let's go back to, because this is also important because they'll ask you this on step 1. If not also step 2. What is how does the sensory get from, so let's say out here you have your finger and then you have a bipolar or unipolar neuron that's the sensory. This is my neuron. So the axon is an afferent neuron. So you touch your finger, let's say someone pokes it and you say, ouch, that hurts. The sensory will travel, the sensation will travel from the finger. It'll go up this, is this I think bipolar. It'll go up the neuron. It'll go up the neuron to the dorsal root ganglion, and then it will synapse into either the cuneate fasciculus or the cuneate gracilis, or gracilis fasciculus, depending on if you're in the arm or the leg, right? So that's your, they love this. Just come back to me. That's your first order neuron. So then the first order neuron was synapse in the second order neuron that's here in the dorsal columns, and then that will travel all the way up to the brainstem. I'm gonna Google this, you guys. This is key. This is important.
Doesn't it decussate quite soon? Like right, like it decussates like at the white commissure, or
something else decussates at the white commissure, not the dorsal columns, but the other.
Ooh, this is taking me back.
Yeah, yield. It's the anterior laterals, what crosses over at the anterior commissure in the spinal cord. but the dorsal column does not cross in the spinal cord. So what they'll ask you, I'm trying to find a good image, is if a person has left-sided vibration and proprioception, where is the lesion in the spinal cord? Is it on the left side or is it on the right side? So what's the answer based on this image here? So we have lower limb, upper limb, cuneate, and you can see that first order neurons, they synapse at the dorsal region of the gray matter. So have they crossed yet if it's in the spinal cord?
For spinothalamic or for
dorsal columns. So they cross in the brainstem, right? So if someone has a lesion, if someone has a left-sided vibration proprioception loss, and I say what lesion could do that in the spinal cord, and I ask, can a right-sided lesion do it, or can a left-sided lesion do it? What would the answer be?
Left-sided.
Exactly, because the dorsal columns has not crossed yet. So the only way to have a left-sided deficit for vibration proprioception is if the lesion is on the left side. Because if it's on the right side, then it's going to affect the right side of the body. And for me, localization, it's something that takes, here's a good image. It's something that takes a lot of repeating over and over and over. So let's pull this one up. But it is so high yield. So let me scroll here. Okay, here's a good image. Oh no, this is the brainstem. I don't want to confuse you guys with the brainstem. Trying to find a very clear image of the spinal cord. Okay, can't find a clear one, but and we can keep coming back to that. Multiple times because that is high yield. See, someone put something in a secure chat. Okay, so let's get back to here. So talk about dorsal columns. Now let's get to the anterior lateral system. We talked about it does pain and temp. So, and then Laura, you brought up that it crosses at they call this the anterior commissure. So the question they like to ask sometimes is, if you have a lesion here, what symptoms are you going to have? They love that question.
would it be on the ipsilateral side?
Well, so because it is basically, if you have a lesion here, you're going to be hitting the anterior lateral. So here's how they'll write the question. Let me use my mouse. They'll say, what are the lesions? Is it right pain and temp loss? Is it left?
It would be bilateral, actually, wouldn't it?
Exactly, bilateral, or they don't like to use none of the above. Or they'll throw you a curveball and say, is it vibration and temp bilateral? Right? That's how they'll write the question.
So bilateral pain and temp. Okay.
Yeah. And the reason why it's bilateral is because it's hitting the anterior commissure and both fibers are crossing on the left and on the right. So that's the answer. Now, I'm going to ask you guys a different one. Let's say the lesion is, and we're just going to focus on anterior lateral. Let's say the lesion is right here. what will your pain and temp deficits be? And we'll call this that this is the patient's right, this is the patient's left, because it's reversed on imaging. So we'll just stick with imaging laterality. So this is the patient's left, this is the patient's right. Lesion is right here. Just focusing on these options here, what do you think the patient's deficit will be?
Wouldn't that be,
Right, pain and temp.
Exactly, very good, awesome. Now, it'll be right pain and temp. Now let's say, I'm trying to get it, make it more complicated. So if, let me think this through.
So
Okay.
basically anything below brainstem has not crossed. So that's why they all fall on the same side. But if it goes above brainstem lesion, then they're all on the opposite side.
That is
Does it
for
make sense?
that is for vibration and proprioception. But if you hit the lesion, if you get a lesion after the anterior lateral system has crossed, then you can get ipsilateral. See, here's how they're going to make it complicated. So let's say we're at the arm, right? You have a lesion at the arm. I think the arm, that might be cervical, thoracic, can't remember. And then they ask you, okay, the lesion is at the arm. What will the pain and temperature sensation be at the legs if the lesion is in the cervical region? So if you have a lesion in the, let's just say you have a lesion in the neck. You have a lesion in the neck on the left side. And I want you guys to tell me, what is the pain and temperature of the person on their right leg and on the left leg? So let's talk about the left leg. If I have a left-sided lesion in the cervical region, will the patient have deficits of pain and temp in the left leg?
no for the leg, right?
Why is that?
It just hits at the level of where,
So it's because these fibers, so for the left leg pain and temp crosses at the level of when it comes in. So the left leg is getting their pain and temp fibers on the right side, but I haven't hit the right side. So therefore, this is not going to be affected because it's crossed. But the right leg is going to have deficits because the anterior commissure, because these fibers of the anterior lateral have already crossed at the anterior commissure, and now they're traveling up. So if I have a cervical neck region on the left side, these fibers are not getting signal to the brain. So I'm going to have a deficit of pain and temp contralateral to the lesion, but I'll have ipsilateral vibration proprioception. You guys, they love these localization questions. And let me show you a picture that you guys want to commit to memory. Let's see.
Yeah, these questions bring back memories. And Dr. Goodell is right. They love to try to trip you up. So it's really important to just have a good understanding of the anatomy and then having a framework for how you approach these questions so that no matter how they ask it, you can get the answer correct. So like the biggest thing to understand with the anatomy is when they're talking about the spinal thalamic tract, that it crosses or decussate in the spinal cord, versus if they're talking about the dorsal tract, then that crosses in the brainstem. So that's the anatomy that you have to understand. And then you also have to make sure you understand, like, what the spinal dilemma tract controls versus what the dorsal controls. So to review, like, the dorsal tract controls proprioception and vibration, and the spinal dilemma controls pain and temperature. And so having, like, those two key facts, once you understand those two kind of key facts, then, like, it's just like putting together the pieces of the puzzle. So they're either going to give you the tract and ask you to talk about the presentation and where it localizes, or they're going to give you, like, the patient's symptoms and ask you to talk about the tract itself. So it's really just making sure you keep those things straight. And it just takes practicing and going over it again and again. So, if you don't get it all the way this time, like, just keep reviewing it over and over, and it'll stick eventually.
Exactly. So here's a really good image that kind of explains what I was talking about. So the lesion I was talking about is called a Brown cord lesion, basically hemisection of the spinal cord. So let's look here first. So this is the spinal cord. This is the midline. Here we have the dorsal column. This is probably the gracilis. That was supposed to be a G. And this is gracilis cuneatus, right? Leg, arm. Dorsal columns, vibration, proprioception. And then we talked about here how, we have anterior, lateral, spinal thalamic tract that carries pain and temperature. So what they'll do on the boards, on the step exam, is they'll say 30-year-old female has a gunshot wound that crosses the spinal cord, causing complete hemisection of the spinal cord. What are their lesions? Which of the following represents their sensory deficits? And they'll have multiple choice. So let's walk through this. So we have a lesion on the right side. And so now we know, well, if it's affecting both the posterior and anterior parts. So we know that posteriorly, we have our vibration proprioception. So we know that's going to be knocked. And we also know that we have, let's just focus on that. So we know that our dorsal columns are going to be out. So yay, okay, we know that, great. First step, we got that. Now we have to know, okay, well, what side? Is it the left side or is it the right side? So they told us gunshot wound to the right spinal cord, causing complete hemisection. So if you just focus on, okay, let me just take it one track at a time. I have the dorsal columns. They don't cross until they hit the midbrain. We're in the spinal cord. So that means that lady has gunshot wound to the right. That means her dorsal column loss is going to be on the same side, ipsilateral. And that's what they're showing here. This red indicates loss of proprioception, tactile, vibration sense on the same side as the lesion. Anyone have questions with that?
No, I just wanted to clarify because this is taking me way back.
Girl, don't worry about
it. So because it's an A.
I'm reviewing.
So it's an ascending pathway that decussates in the thalamus, I believe. And so with that being said,
in the thalamus? I thought it, let's look it up. Can someone look it up? My internet wants to freak out. I'm a visual learner, and then someone else can share their screen once they have it up, just so we all on the same page. Go ahead, Laura, sorry.
Oh, no, you're fine. So because it decussates there, that means that you're gonna have, that's what explains the ipsilateral deficit versus the contralateral deficit in regards to that specific track.
Exactly, yes. So
whereas the
lesion is occurring before the crossing of the dorsal columns. So that's why it's
Right.
really important to know when it crosses. So we know that, like, I can't remember if it crosses in the brainstem or in the thalamus, but someone's gonna help us look into that. So yes, so because it doesn't cross in the spinal cord, this lesion's in the spinal cord, well, then it has to be on the same side. So now things are gonna get a little bit complicated. So now we're done talking about dorsal column. So now let's talk about anterior lateral region. So maybe for this session, we should just focus on anatomy. We can do cases when Mattia feels better. Yeah, let's just focus on anatomy, because this is a good refresher for me too. Is that cool with everybody? Because I feel you can't do cases unless you know the anatomy. So I think it's good for us to just review the anatomy. Oh, so here's the question. Let's pull it back. How many cervical vertebral columns do you have? You guys can say it in the chat. You can say it out loud. How many?
Is it 8?
7.
7.
Oh, 7, sorry.
How many cervical nerves do you have?
8.
Good job. How many thoracic vertebral columns do you have?
12.
12.
Fantastic. How many thoracic nerves do you have?
12 as well.
12.
Fantastic. How many lumbar vertebrae do you have?
5.
Huh?
5.
5.
Five. Fantastic. Like 5 days of the week. How many lumbar nerves do you have?
5.
5.
Awesome. What about sacral? Wait, hold up.
5 as well.
Okay, sacral bones.
Is it 4?
5.
5.
5.
5. Okay.
But know that you won't be able to see all 5 on your imaging. They're just always fused. How many sacral nerves do you have?
5.
No. Good try though.
4?
No. Good try though. What's left?
7? No. Or 6.
Oh, you guys, I'm so sorry. I'm so wrong.
I was gonna say, I'm just gonna do it.
Oh,
5.
no. So she's like, no, it's not. It is 5. See, this is what I'm glad we review this together. It's 5. Good job. Forget it's so we have 8. So let's focus on the nerves. We have 8 cervical nerves, 12 thoracic nerves, 5 lumbar nerves, and 5 sacral. Okay, cool. Cool. Did anyone find the pathway for the dorsal columns?
Sorry, I was getting there. Give me 1 second.
Cool. Oh, I missed you guys. This is so much fun. Nerding out with neurology.
I was hoping I can find it in some old notes, but I might have to do that. I might have to ask Google.
My internet is like, oh, if you add any more tabs, you're gonna be unstable. I'm like, okay, fine, just not gonna add no more tabs. Okay, while you find that, Lauren, so now we talked about dorsal column. Now we're gonna talk about spinal thalamic. So spinal thalamic is going to be anterior lateral. It's gonna carry.
Looks like the screen that you're showing is still the internet.
Huh? Do you
Oh, sorry. This is the one you meant to still show. Okay. I thought you were trying to show the textbook.
Oh no, do you see my screen?
Yeah.
Cool.
Sorry.
So if the lesion, so this is going to be the left, this is going to be the right. And that's one thing I recommend when you guys are doing neuro questions, just always know your laterality. Like before you even read the question, okay, this neuro, I'm going to mark it. I do this all the time. This is my right, this is my left, this is my right, this is my left. And know that it's reversed because of neuroimaging and how the patient is situated in the scanner. So know that it's reversed, always write down the paper, and that helps you when you're presenting you don't get doesn't get crossed in your mind. So right, left, right, left. Anterior lateral is here. So let's just mark it on this side. So the lateral part is here, anterior part is here. So they're saying that if you have a Brown cord lesion on the right side, we know that these fibers cross at the anterior commissure and then they travel their way up. So at the level of the lesion downward, you're going to have contralateral loss of pain and temp. So if you have a lesion on the right, you're going to have issues on the left. And that's because of the anatomy. Oh, thank you. Thanks, Seema. Going to open this if it'll let me. Seema, if it comes up on yours.
Oh, it actually popped up as an image.
Oh, it did? Is it popping up on the image for you?
Yes, I opened it in the, let me send the Google link.
If so, you're welcome to share your screen. Okay, so that's that. And while we get those images up, know that, study it, look at it multiple times, and then we can, always do more neuroanatomy because they love those questions. Okay, so we talked about the major. Now let's talk about the motor. And at least from the spinal cord perspective, the motor, so you have the dorsal horns, and then you have the ventral region. This is the white matter, this is the gray matter, and then you have anterior horn as well, the cell bodies of the motor region. Motor nerves are. Let me find my. So you have your anterior cortical spinal tract, and then you also have a lateral cortical spinal tract, and these are carrying motor nerves that transmit signal to your muscle to contract, relax, where's your muscle in time and space, Golgi tendons, etc. So for this tract, so you have two ascending tracts for the most part that they're going to test you on, the spinal thalamic and the dorsal columns. Then you have one major descending pathway that's high yield. There's other descending and
Cortical spinal.
What?
The cortical spinal tract for the descending.
Yeah, the cortical spinal tract is a descending. So what that means is that it starts from the brain, and it goes all the way down to the muscle. Whereas the ascending means you start from the sensory nerves and it goes all the way up, and the signal gets transmitted ascending pathway. So ascending, descending. So from the motor standpoint, the nerve starts from the primary motor cortex, and then sends axons down, and then it crosses at the medulla, at the pyramids, and that's why in stroke you get contralateral motor weakness. So if you have weak arm and leg, the lesion is not going to be on the left, it's going to be on the right because it crossed at the midbrain. At the medulla, at the pyramid, or decussates at the pyramids. Let me find it.
That makes sense.
Oh.
We think about it all the time in stroke, how it crosses over. But then, like, when you think about the ascending tracts, I don't know why it's so confusing to think of it that way. But yeah, we see contralateral symptoms in stroke all day, every day. So then it's like literally the same thing in the ascending tract. or at least for the spinal dilemma, the pain and temperature tract. It crosses over too. And my bubbles went off. Thank you, Dr. Goodell.
Anytime, Dr. Akituman, I'm happy to help. I'm trying to find, oh, you guys, I don't want to confuse you guys. I don't want to confuse myself either. Oh, different cord lesions. This is really good. I'm just trying to find the tract for the motor. Anterior lateral, posterior columns. Did I miss it? Central pain. Okay, we'll come back to this because this is how they're going to ask you the questions on step 1, step 2. So they're basically going to say transverse cord lesion. What are the deficits? Central cord lesion, syringomyelia. Addie, that's what we talked about with the spinal or cauda equina yesterday. They're going to ask you what's the lesion, central cord lesion. They're going to ask you what's the deficits. Hemicord, we talked about Brown-Séquard. They're going to ask you, so we can go over posterior cord, you know, just bilateral loss of vibration, proprioception. So we'll go over this. That's actually really good. Thanks for sending this, Seema. Oh, they have cases. Okay, we'll do this one too. Yes, I'm very happy to help. Thanks for the feedback. Yeah, I'm excited. I just love neurology. Just love it, and I love talking neurology to other people that also like neurology. We're learning together, and it's just fun. Okay, we'll get to that PowerPoint. So let me see if there's anything else high yield. So we talked about the spinal cord tracts. I think this might show up on step 2, step 3. Now we're going to get into the blood supply. So whenever I look at an image, I like to orient myself. So so this is going to be posterior. This is going to be anterior. This here is your gray matter, and then out is your white matter. So always orient yourself when you look at an image before you interpret the image. Orient yourself, because that gives you time to figure out what's going on. So we have, this is the back. So this is going to be our dorsal columns. We're going to have anterior lateral spinal dylemic on this side here. And then we're going to have our anterior horns with the motor. Let me get a different color. With the motor here. So what they could ask, they love asking this question. From a stroke standpoint, they could say, patient comes in, Addie, you see this all the time. Patient comes in and they have a stroke, because you can have it, it's rare, but you can have strokes in your spinal cord. Has a stroke affecting the anterior spinal artery. They're going to ask, what's the patient's deficits? And they'll give you multiple choice. So what do you guys think?
Pain and temperature.
Exactly. So we want to think, okay, so what is in the anterior region of the spinal cord? You got your anterior lateral tract, and you also have your motor tract.
The anterior cortical spinal.
Yes. Yep. Because the first order neurons, the cell bodies are right here in the anterior horn of the gray matter. So if this whole region is knocked out, you're not going to have any motor sensation that's communicating, going to the brain all the way down. So that means motor is out, and motor is not out on the right or the left. It affects both. So motor is out completely. So that person is plegic. Paraplegic versus quadriplegic, depending on the level. If the level's in the thoracic, that person is paraplegic bilaterally. Right and left is out, because this anterior spinal artery feeds both sides of the spinal cord. And your pain and temp is also going to be out, because anterior spinal dylemic is here, lateral spinal dylemic is here. It's on both, it's hitting both sides, including the commissure, so it is out. I guess the brain is not able to get the information because the first order neurons are out. So that's how they love asking these questions. What is not going to be a deficit? That they love that too. Which of the following is not a deficit?
Like vibration, proprioception.
Exactly. That will be preserved because the anterior spinal artery feeds the anterior portion of the spinal cord, and vibration and proprioception is posterior. They love that. So now let's say I reverse the question. I don't say anterior spinal artery, I say posterior spinal artery. What's your deficit going to be?
Proprioception, vibration.
Yes, exactly. Just like the vitamin B12, neurosyphilis. Exactly. Very good. So no those two arteries, no spinal or anterior spinal artery and posterior spinal artery. That's high yield neuroanatomy. Let's see if there's anything else. Oh, dermatomes. So know that dermatomes are really representing spinal. What is the sensory innervation coming from the spinal nerve root? This is before it branches into a more distal neuron. So they love dermatomes. And so the key dermatomes that you should commit to memory include the nipple, which is T4. And the belly button, which is T10. I think those are the big ones. Are there any of the big ones? I think those are the main ones that they love asking. T4, T10. Belly button, and the nipple. Those are the main ones. I'm not saying you shouldn't know others, but those are main ones. And then once you know those, you can add on. Let's see. Oh, look, they have the syndromes here. All the different syndromes that we talked about. And we can talk about, I like the other PowerPoint better, so we can go through the PowerPoint with that one. I won't do cases. Let's keep talking anatomy. I won't get into that either. Okay, so let's go back to that PowerPoint.
Can you go back to the syndrome, the box with the syndromes?
This one?
It's in the other document that you pulled up.
This one? This one?
You just scrolled past it. Go back to the document you were just in. And then when they talked about the cord syndromes,
This one?
it's like red and gray.
This one?
Yeah, this one.
Okay.
The common types of incomplete spinal cord injury.
Uh-huh.
So like, I think when you're first looking at this, it seems like there's a lot of options, but you really, looking at this, you really only have 5, right? It's either gonna be the posterior, anterior, ground support, which would be like left or right. So that counts as 2. And then the central cord. There's really gonna be only 5 kind of like major cord injury patterns. And so if you can keep those straight, then you'll be able to like answer any of those questions that come up. But it seems like it's a lot, but like this box here, like this is what you want to have a good understanding of for those questions and the cases.
And once you know your anatomy, I mean, we can based upon what we discussed, we can enter these now. So branchial cord we talked about, central cord lesion we talked about. They love this like cape-like, distribution where you're gonna have more issues with the hand versus the feet. And then for posterior cord we talked about, you get impaired sensory with vibration, proprioception, and anterior cord. So you guys already know all this. We talked about it. You guys like, boom, you get a step question, you'd be like, I got this. So just a lot of repetition. But yeah, I think Addie brings up a good point that this is key, because I remember trying to study this, like, oh my gosh, I'm never gonna know this. Just makes no sense. It's confusing. I don't like neuroanatomy. But you know, so it's hard. Like neuroanatomy kicked my derriere when I was a med student. It really did. But that's why I do these study groups, so that you guys don't have to go through what I went through. Try to make it easier and more fun.
Same.
And trying to break
Still,
it down.
still kicks my butt,
Yeah.
but it's doable.
Laura was
No,
teaching me
seriously,
that
like this stuff. And
before.
even if you're not, I know there's a lot of medical students here, but even if you don't go into neurology, I'm in emergency medicine. These spinal cord injury patterns come up all the time. They always come up. So just know these 4, 5, if you do right brown support and left brown support, and that is it.
Yeah, they're definitely high yield and all the board exams. Oh, I'm just loving all the great discussion in the chat. I'm gonna make sure we include this in the recording. So Laura said, Laura, how about you want to explain what you said in the chat?
Yeah, so I know you mentioned the anterior spinal artery and sort of the deficits that would come with that, and infarct in the, or stroke in the anterior spinal artery. So just it kind of took me back to when we were in a previous case discussion talking about like the train of fours and the artery supply that's lateral and medial. And I just kind of, it just rang a bell that stroke in that particular blood supply in the anterior spinal artery, which often is located in the medial medulla of the brainstem, would then, that's normally where you would find that infarct, which then makes sense. And it reminds me of like when you have the vertebrals coming up and you have that little anterior spinal artery kind of coming down from that. So.
Thank you. Can you guys see the chat when I put it in the screen? Or no?
No,
You don't see the chat?
not on your screen.
Oh, okay. I was pulling it up. Okay, that's good to know. Cool. Awesome. So I would really love to know how these tracks, we should find a good resource that has how these tracks show, like, go up in the brainstem. You know, like how they travel, what's their pathway? In the visual.
For the posterior column, I did have that, I don't know if you can pull up that Google that I put in chat, the Google link.
Yeah, I think Sarah has a nice link for the cortical spinal tract.
I'm gonna stop sharing my screen. Anyone else want to pull it up? Because it wasn't pulling up for me. And maybe I have to change my settings. I can't remember. Are you guys, is it allowing y'all to share screen or no?
Let me see here. Okay, let's see. It says host disabled participants screen sharing on my end. So.
Man, how do I change that? How do I change that? Okay. I can make you co-host. See if that helps. Okay, try that. Awesome.
So
thank you.
Here's the posterior column.
Oh, yeah.
So,
so it is in that same link. Oh, okay.
So if you
go ahead.
notice here, you have the eighth. Here's like the first order, and then it synapses here at the cauda medulla, which is what you were mentioning. then it ascends up from the cauda medulla, which is in the brainstem, and then goes to the VPL of the thalamus. So that will be the third order.
Awesome.
So first, then second, and then third.
Awesome. And sometimes I think on step one, they'll like to ask like specific anatomy landmarks. So the landmarks that's important to know, again, I'm not saying not know everything, but I'm just trying to remember what was high yield for me when I was studying is this medial lemniscus. That is very high yield. So trying to think what else. Dorsal root ganglion. So if you have a lesion in the dorsal root, know that a dorsal root. Oh, thanks for coming. I'm glad that you enjoyed the conversation. Dorsal root ganglion is also high yield. That is technically not in the spinal cord. It is outside the spinal cord, so it's a ganglion in of itself. So first order neurons for vibration proprioception is here, and the dorsal. First, they'll ask you, where is the cell body of the dorsal column pathway, and they'll give you, is it the root ganglion, is it the spinal cord, is it the brainstem, or is it the cortex? And the answer is it's the root ganglion. Those, I remember that for step one. So
Yeah, I remember that too.
and then they may ask, where is the cell bodies for the second order neuron for this pathway? You'll say, well, the cell bodies are in the spinal cord at the dorsal columns, which is right here. So know where the cell bodies of the first, second, and third order. So the cell bodies for the third order would be in the thalamus. And then they travel in the brainstem via the medial lemniscus. So those are the big takeaways from this that I would know. And they cross over at the caudal medulla.
Right.
Awesome. So then, thanks for that. So then I want to share
Let me
my
stop sharing really quick.
and I'll go back and share mine. So it's in here. Can you scroll up? So now we talked about dorsal lateral pathway. We can also review the entire pathway for the anterior lateral system. So we've started here. The first order neuron cell bodies are going to be, unlike in the dorsal columns where the cell body was in the dorsal root, the cell body here for the first order neuron is in the gray matter, in the spinal cord. Am I saying that right? No, you guys forget me. Wait, am I saying that right? Am I saying that right? Am I wrong? Nope, I'm wrong. Erase, we're gonna erase. Okay, let's start over. So again, it's gonna be in the dorsal root ganglion, just like the vibration proprioception. You're going to have an ascending pathway from the finger or the toes or whatever sensation that's part of the body. Then it's going to travel and it's going to synapse here at the dorsal horn of the spinal cord that's in the gray matter. Now this is going to be our second neuron, second order neuron. This second order neuron is going to cross here at the anterior commissure and then travel as part of the anterior lateral pathway. And it's going to go all the way up anterior laterally. And look, and then the third order neuron, then it's going to send the second order neuron will synapse here, and you know what? I do think they like to ask the actual name of the thalamus. So know that for the anterior lateral, it's going to be the VPL.
Mhm. Right.
They love asking that for step 1. That's third order neuron cell body. It's going to be in the VPL, and then those neurons will go up into synapse at the post-central gyrus. I need to add this to my notes. This is a really great resource for memory. Okay, so just look at that over and over and over again. And I had a professor say, you don't know it until you can draw it from memory. So that's how you know it, because what will happen is you think you know it, but then when you get to the exam, high pressure, high stakes, you blank. You're like, oh, but you know it only if you can draw it out verbatim multiple times over again without looking at any resources. So that's how I practice neuroanatomy. So that'd be my tip for you all. It's just,
for some reason, I'm just coming back to memory as far as Brown-Séquard with the hemisection.
Thanks, Patty. See you later. Go ahead, sorry.
With the it's kind of just bringing back to memory, sort of. So what would you have like that? I think there was like, oh, you're gonna have contralateral like pain and temperature loss, but then like at the level, you're gonna have like above the level some like pain and temperature loss. Am I making this up? There's like, I thought I'm just reading, I'm just recalling something. I don't know if that's correct or not. Like below the level contralateral, but then at the level a little bit above or something.
Yeah, I remember. I have to look more into that, because I do remember, at the level you get one lesion, and then below the level is something. So let me do some more reading into that.
You're talking about the crossing over, right, Laura? Like
Yeah.
below the crossing over level, it's the ipsilateral lesion, and above it's the contralateral, and at the section, I think it's the hemisection, you'll have the bilateral. I think that's the one you're talking about, right, Laura?
I was just trying to put the puzzle pieces together when you were explaining it. So I am talking about that with the hemisection. I remember seeing like a picture of like the guy, and it's like the lesion's on the right side, and so it's like there's like, how they color it. Oh, they always like color it, like here, and then it would be like uneven. It'll be like this or something, and it's like, oh, above the level of the affected side, like it's above level, like spinothalamic, there's some pain, but then contralateral, it'll be completely gone or something. But I don't want to start talking like making something up. So I just so vaguely remember something like this, and I just wanted to kind of make it make sense. So I'm seeing if I can maybe pull up some of my really old notes here. Let's see. It was like at the level and then below the level, one of those kind of things.
I remember what I have a picture in my head of what you're saying, but I'll have to look it up and read more into it. And then unless anyone knows, Seema, sounds like you know what she's talking about. If you want, or we can next time we do myelopathy, we can bring that up again, Laura, if you remind us.
Yeah, that'd be great.
I don't
know. I'll see if I can like kind of real quick look it up while we're continuing our talk. Cool. But I'm just glad I'm not, I feel like I'm not making this up.
No, you're not. You're not.
Okay,
Either
I
way.
think this is what you're saying, right? Like at the site of hemisection, it's a lower motor neuron lesion. Below the lesion, it's loss of vibration and position sense, upper motor lesion. Let me share that picture. I'm trying to look, see if I can find a picture. This is what I can find. Let me share that.
This is why it's great to have multiple people in study groups. We put our collective minds together and we're unstoppable.
Oh, it's not allowing me to share. Let me see if I can share the link.
Oh, I made you co-host so you could share. Let me, I made both of your accounts co-host so you'll be able to share now. I need to update the Zoom settings so that everybody can share.
Can you see that Wikipedia link? If you click on that link, you can see on the right side, if you scroll down a little below, you should be able to see that hemisection versus below the section.
Okay, so if I scroll, oh, I remember this image. Ew, gross. Gives me PTSD. Ew. Okay, who wants to explain it? I'm gonna have to read
It
it.
actually, oh, there.
You see it?
Okay. Hold on, let's see. Yeah, that's exactly what I'm talking about.
Yeah.
Okay. Seema,
So-
take it away.
Yes, so basically, hang on a second, give me 1 second. Okay, so basically, this is like the spinal cord, and this entire section is, the lesion. So you have like the anterior and the posterior tracts, right? So that's why you have those different levels. Like if this is a hemisection, below it and above it, you have the different lesions. So that's how you have to imagine. That's where the Brown-Séquard syndrome is.
Oh, so is this just? Oh, so this is for Brown support. Okay.
Yeah.
So then this would be the right. This would be the left, and then it's saying at the level of. Sorry, the lead.
So that would be like at the hemisection, like this entire half, like both anterior and posterior, tracts or columns are affected. Like if this is the spinal cord, like, sorry, I'm not showing the best spinal cord image, but I'm just saying like this entire half, that's at the level of lesion.
Okay. And then what's the peach? And then at the level below the lesion. Oh, I see what is going on. So at the level below the lesion, do we know what the peach color represents? So lesion on the patient's right, loss of all sensation, hypertonic paralysis, meaning no tone, that's lower motor neuron.
So the peach is below the lesion. And the one on the left side, is that, didn't say right, left? Yeah.
The green side, yeah.
So the
left
one
side.
on the left side is contralateral loss.
Uh-oh.
Sorry, I clicked
let me
on.
see if I can.
So then the question is, why is the part that confuses me, like, why are the colors not equal? Why is it this big drop? Like, why wouldn't it just be like, whoop?
I do know that I think it's for the anterior lateral. It's like it crosses over 3 or 4 levels. Like it enters and then it crosses 3 or 4 levels. So there's like some redundancy. That's this pull is pulling me back. Something like that.
Here, let me share another picture that I found.
I'm going to.
Oh, okay. I see, because it's not you're saying the anterior white commissure where the spinothalamic tract decussates or synapses, it then travels a couple,
I think
like-
there's redundancy, but
like it,
let me look.
or,
Okay, looks like someone put something else in the. Should I click on the second? Okay, the second link. Oh, this is a really good website. Waiting for it to load.
So you can see the one it shows, there's damage to the corticospinal tract. Because it's the damage to the tracts. We have the main corticospinal tract, right? So that's the main tract there. And then, so corticospinal tract is the one which goes all the way from the head to your toe, right? If you recall the entire tract pathway, it goes all the way from your cortex to the great toe. That's the corticospinal tract. So that's the main one which is affected in terms of like which side is the lesion. Does it make sense what I'm saying?
right. So I guess I was more so, I think I was just more so bogged down on like the fact that but now I'm like, but now this guy's got his pants on equal length. So
Yes, so if you look on the left side, all that, grid area on the left side, I'm sorry, not left side, right side, the spinal image, all that grid area is the affected section. So you go above that and you go below that grid on the right side image. Yeah.
So Laura,
So-
were you asking about this region here that I'm shading in red?
No. The right image of the spinal cord, you see the brown, the spinal cord section.
Oh, I see. So there's a discrepancy here. So here it makes it seem like anything below the level is out, but on the other image, it made it seem like so many levels on the other side down. I see what the confusion is.
right.
The discrepancy.
So is it just, was I thinking too deep? Like, is it, you
No,
see like
I think it's a fair.
So basically, Laura, for corticospinal tract, the crossing over happens in the brainstem, right? So anything below that is all ipsilateral.
everything, wherever the lesion is from that point down is screwed. Yeah. But yeah, so here, he had, like I said, like the colors
There's a
kind of like,
discrepancy, right?
but you see how like there's a massive like all like you see how the orange and green like there's this
match up.
massive
That's the not just the motor, that's the other ones, the pain and temperature, because they have that distribution, right? Like anterior and dorsal columns. So
because just
like,
on the contralateral side, it's just the
yeah.
inside.
If you go,
But then
if you go back to that same image, Dr. Igudaro, the one that EPO medicine, that link, if you scroll down, you can see that there.
Oh, okay. Hold on, let me do that.
Yeah.
Oops.
Yes, below. Yeah. If you scroll down, we can see it.
Oh, I think my computer is loading. Wants me to close some tabs. Okay, if I scroll down. This one
Yeah.
here?
No, just go up. It shows 1, 2, 3. Yeah, right. No, just go up a little more. Oh, wait, sorry. Go back to that image just below the image, you could find the 1, 2, 3 to show what it.
Oh, I see what you're saying. Okay.
Yeah, right there. Yeah. Yeah.
The image of dorsal columns below the level of decussation. Okay. Damage of at the level. Oh, so you wouldn't have, oh, this is getting confusing. I'll let Seema explain it because she has a better handle on it before I confuse everybody.
So it's the motor components is all ipsilateral, but the sensory one is the one which is contralateral. Do you understand what I'm saying?
Spinothalamic is contralateral.
Yes, that's the sensory one, right?
Oh, okay. So here's what this image is saying. So at the level of the hemichord loss, you're gonna have your anterior-lateral sensory out and your dorsal columns. They're both going to be out on the same side because that's both those pathways are coming in at that level. And if they can't, if they can't come in, they're blocked because that whole thing is dead. So at the level of that gunshot, ipsilaterally, anterior lateral and dorsal columns are out at the level. But when you go down, it gets flipped because for the anterior lateral, those columns, those pathways have already crossed. So at the level, so basically we're talking about two main tracks here. We understand that the motor is going to be out. That makes sense. But what's going to be different here is at the level of the lesion, the two sensory tracks are going to be out on the same side. But below the level of the lesion, one tract, the dorsal columns, is going to be out on the ipsilateral, but the pain and temp is going to be out on the contralateral. And that's what this is showing here. At the level, the two tracks are out, but then below the level, those tracks split.
That's why I said, look at the diagram on the right side, the one which showing the grid, the section of the spinal cord. Yeah, that one. Yes. So if you can see this, you can see like one half of the spinal cord is gone. So we just identify which is the dorsal column, which is the anterior column, and those are the tracks affected. And the corticospinal tract is all the way from head to toe. So that's there in every spinal cord lesion injury.
And what we can do is we can bring this up again at the next study group, and then we'll ask you questions, and then it'll help solidify the concept. And we can do this over and over and over again until it sticks, because this will not go away on the board exams.
Yes.
Awesome. So let's see, what else? So we talked about anterior lateral pathways, somatotopic organization. That's not high yield on the boards. For y'all, we talked about ascending pathways, descending. The big three to know is the cortical, spinal, anterior lateral, and dorsal columns. Just know that you have cerebellar tracts like pectospinal, rubospinal tract, pontine reticulospinal. That is all, those are pathways that feed into the cerebellum and that helps with like stability, of movement. So if someone has ataxia where they're wobbly, know that that can be due to a spinal cord lesion because you have pathways that go in and out to the cerebellum. But that's, I really stress about these pathways. These pathways are, if you know everything and you want to know more, okay, come back and learn those. But you guys have enough to know already. So I wouldn't worry. Those are not high yield, is what I'm trying to say. Central pain modulation, that's not first step. The big things to know from the thalamus, who remembers where does the anterior lateral tract, what are the third body, third order neuron cell body for the anterior lateral tract located. That's how they're going to ask the question.
The VPL of
Exactly.
thalamus.
Yeah. So know that. No VPL. Good job. And then you should also know the one for there's LPM. I can't remember which one that's for. But maybe they'll show us. Let's see if it shows us here. I'm looking for the dorsal columns where that is at, third body neurons. Oh, it's also VPL. So they're both VPL. So you have the medial lemniscus, which carries the dorsal columns. You have the spinal dilemma tract. So they both were going to synapse at the VPL. They love that question, especially on step 1. So and you guys already know it. Wouldn't worry about the other ones. Well, the other ones are not high yield. Let me see that. From what I remember. Okie dokie. Clinical dysfunction. I think another thing we can talk about here, since we're talking about the spinal cord, I think we already talked about, this is a really good resource that Seema sent out. It talks about all the different lesions that Addie was mentioning in that 4 box. This one goes into a bit more detail. So I would just commit these to memory. It's really good. Another thing that we should talk about is when you have a spinal cord lesion, they love to ask, what are upper motor neuron pattern versus a lower motor neuron pattern? Upper motor means spinal cord. Upper motor neuron means the problem of the lesions in the central nervous system. And then lower motor neuron means it's in the peripheral nervous system. So the peripheral nervous system starts after the nerve exits the spinal cord. That's peripheral. Spinal cord and above, you got the brain and spinal cord, brainstem, all that is upper motor neuron. So what they like to do, patient comes in with hyporeflexia, which means reduced reflexes. They have fasciculations on their tongue and their muscle. And the question is, what kind of pattern is this? Is this lower
motor? Exactly.
Patient comes in and they're hyperreflexic. They have spasticity. What else? Those are some of the key ones. Is that upper motor neuron or lower motor neuron lesion?
Upper motor neuron lesion.
Exactly. So that's kind of how they like to ask those questions. So just know the difference. And I'm a visual learner. I commit this chart to memory because this is high yield. Oh. Here's a table. So lower motor neuron lesion, muscle strength is going to be weak. They're going to be plegic because they don't have any nerve innervation to the muscles. The muscle doesn't have any signal to move, so it's not going to be able to move. Tone, you're going to have, they call it flaccid tone, which is just basically, you pick up their hand, it just drops. Well, you can also see that in an upper motor neuron lesion. Tone, it just means that it's hypotonic. It has no tone when you move it. There's no resistance. It's just like that. That's no tone. You're going to have atrophy of the muscle. So when you look at it, it's going to not have muscle bulk. It's going to be cachectic. It's going to be atrophied. And the upper motor neuron, initially, well, let me not confuse you. Initially, you can have reduced tone, and then over time, it'll become increased tone to where when you try and move it, you know, there's resistance. You're going to have, so you'll see this in like stroke patients. You know, acutely when they have their stroke, they're going to have low tone. But over time, if you see them in a week or two, they're going to fit more of an upper motor neuron lesion to where they're going to have spastic tone. They're going to have, when you hit the reflex, they're going to be like hyperreflexic. They're going to have upgoing toes. When you do the reflex on the feet, their toes go up. That is significant for an upper motor neuron pattern. Normally after, I think after, you know, after we grow out of being babies, initially when we are born, our toes are up. But then after a period of time, they're down, and that's normal. But if we revert back to toes being up, that's abnormal in adults. That's the positive Babinski. You don't have atrophy really of your muscles in the upper motor neuron pattern. That's only really low motor neurons. And some of the causes here of stroke causes. Go ahead.
Would multiple sclerosis also be an example of upper motor neuron, the demyelination in the, okay.
Yeah, good point. For lower motor neuron, anything that really affects the lower motor neurons, like they say here polymyelitis, motor neuron diseases, spinal cord, peripheral nerves. So like carpal tunnel syndrome, where you have a injury to your median nerve, which is a peripheral nerve. You know, you look for atrophy of the thenar muscle. You look for they're going to be that's pretty much it. And then depending upon where the compression is, you can have absent reflexes, muscle wasting, etc. So this is ideal to know. I'm trying to think of other big things in the spinal cord from an anatomy standpoint.
For lower motor neuron, is Guillain-Barré also an example as well?
So Guillain-Barré is, it could, so it's a polyradicular neuropathy. So yeah, I would say because it's really affecting the roots, it's ascending paralysis.
Yeah, I think it does have absent reflexes, I believe.
It does.
So I think it would qualify.
Yeah, polyradicular neuropathy. That's the long name for it. PBS syndrome. So it affects, damages peripheral nerves. Polyradicular neuropathy. Oh, it doesn't give me the long name for it, but yeah, it does affect the peripheral nerves. Thing to know since you mentioned GBS, know that it's associated with Campylobacter, like the buzzword for your step exam is associated with Campylobacter jejuni. This is more for step 2, step 3. And it's an ascending paralysis. So subacute, they'll have issues in their feet, and then a couple of days later, they can't walk or trip over themselves. And then days later, they can't breathe because it's working its way up. And when you do an LP, you get that albuminocytologic dissociation, where you have elevated protein
in the CSF.
Exactly, but no elevated protein. Yeah. Cool. I think anyone else have anything else they want to talk about from a spinal cord standpoint? Those are, I guess, focusing on the anatomy is key, because then now that we know the anatomy, we can then start doing cases. Trying to think, we have 15 minutes. Trying to think if there's anything else that's high yield from a spinal cord standpoint. It's also good to know, like, spinal root lesions, spinal roots for like the reflexes. They love that. So if they say, what is the spinal root? They say you have absent Achilles reflex. What root does that associate with? They love asking those questions. So we can
Absent which one?
Achilles, is that like S5 L5 or
Let me pull up an image here.
Did you say Achilles?
What?
Which one did you say absent?
So let's say you have an absent, okay, this is hold up. Let's say you have an absent like Achilles, or you have an absent plantar. I remember the plantar showing up. They just love asking it. So just kind of know what that localizes to. So if you have absent knee jerk, then that localizes to L4.
Yep.
So the front of the leg, most of it is all lumbar, except for the great toe, which is S1.
That's also high yield. They love asking those kind of questions as well. They even asked this on my step 3 exam.
Yeah.
So no
For the
root.
Achilles tendon, it's also it's L5 to like S1.
Yeah. Except only the great toe is S1, but
I
the
see.
majority of front of the leg is all lumbar. And it goes like this, I think. L1, L2, like that. So,
Cool. I think that's what we talked about. Dermatomes, biotomes, not really big. Talked about spinal cord levels. Talked about the tracts going up and down.
and back of the leg is all sacral. The front of the leg is all lumbar. Dermatomes.
Let's see.
And I think the favorite question for step 1 I recall is the front of the leg is lumbar, but when it comes to the groin area, it's sacral again.
Oh yeah, here's a good
That actually makes perfect sense now, Seema, because that now brings me back to like cauda with that's why that affects the posterior leg
Yes.
versus the anterior leg. That makes perfect sense. Okay.
So here we have motor, then we have reflexes, then we have sensory. So at the L4, you have absent. So if we look at the motor, you will have your tibialis anterior be affected, so that dorsi flexion is going to be affected. You will have absent knee reflex, and then you have decreased sensation in the front shin region down to the medial aspect of the big toe. This is a really good image. I need to put this in my notes. And then L5 is going to be extensor of the toe, and then the medial or the front part of the foot, decreased sensation. I've really seen a lot of L4 S1 because it corresponds to reflex. And then for S1, is that Achilles reflex. That's going to be absent. That's going to affect the lateral. The motor, you're going to have deficits in the peroneus. You're going to have deficits in this looks like eversion.
Dorsiflexion, eversion and dorsiflexion, I believe, for the peroneal nerve. So that's why they'll have like the foot drop if that's affected.
And then for S1, it's going to be the lateral aspect for sensory, the pinky toe.
Oh, sorry, lateral aspect, not the medial, but it's the groin area, I think. Yeah.
And then for S2 to S5, it's really going to affect, like what Seema was saying, the anal region, anal wink. That's going to be, that's why in patients are concerned for cauda equina or conus medullaris. Someone has to do that rectal tone exam. So you want to see if it's absent. And then cline of the toes. I guess toe flexion. That's a really good image. Cool. I think that's all I have. I think that hits all the big stuff from a spinal cord standpoint.
This was a tough one. This was a true tough one.
But we did it. We got through it together. And then in upcoming study groups, we can always pull back, anyone like, oh, how many spinal cord levels do we have? Or what's the innervation of the Achilles tendon, And then that's how, if we keep.
Oh, the other key thing I recall is like, if you put your hand on the hips, like the highest point of the iliac crest where you feel the bone, that corresponds to L1, right? Or L4, I forgot.
That was L4.
I don't,
The highest point of the crest, that's L4 or L1?
L4, because I thought that's where you do the lumbar puncture. Like that's
Yeah,
like the
yeah,
sort
that's
of the
the L3 level,
anatomical.
right?
That's like the anatomical sort of
Yeah,
um
L4, yeah.
awesome, awesome. Anything else anybody wants to bring up or discuss?
We should do this again.
Yay! Awesome, like another like just anatomy.
Yeah.
Cool. Yeah, I think yeah, we could definitely do that. I think I can look. What's another y'all? We should attack this brainstem anatomy. Maybe that's what we should do. Maybe next week, one of the days, we can just attack the brainstem. What do you guys think?
of course. Of
Yeah,
course.
oh, actually, Gabriella, she's a physician in Brazil who just matched for neurology here in the US. She does a lot of beautiful infographics, and she has a lot of stroke syndromes, like the lateral stroke syndrome, medial, medullary, and I wanted to use some of her infographics and incorporate them into like brainstem lectures. So I was gonna pick her brain because I think she wanted to lead some of the brainstem because for her infographics. But yeah, I think we can definitely keep doing, maybe we can do one session of anatomy at least once a week, because that's something I can definitely refresh on.
Yeah, for sure. Yeah. Looking forward to the next session then.
Oh, I think the next one will be on Friday. Seema, we're doing
Yes.
transverse myelitis. Is that what we're doing?
Sure, I'm not prepared.
Oh, no, tell me what we're
Yeah.
doing. I can't remember.
Yes, transverse myelitis, yes.
Okay, cool.
Seema, I'm noticing you're picking all the hard topics.
Yeah, those are the ones I actually don't remember, so I figured that would be good memory.
And that's really good to pick, to pick the topic, because then, it forces you to like learn it and then you present it. So if for those on, be sure to sign up for Thursday's session from 7 to 9 Central Standard Time. We were doing transverse myelitis, and next
Oh,
week.
it's Friday, not Thursday.
Oh, that's right. Sorry. I need to change this. I need to change. I'll do that tomorrow. Friday. Yes, it's Friday, 7 to 9, not Thursday. I'll update the calendar. And next week we could sprinkle in neuroanatomy at least once a week. Laura, would you like to talk about the rule of fours next week? And I'll add on we could do some like neuroanatomy questions. Maybe
Yeah,
that'll help.
I would love let me look at my availability for next week. But let's do it. Let's do train of fours. Yeah.
Awesome. And then I'll add questions that we could go through together for localization.
For sure. Sounds good.
Thanks, everybody.
We
Have
should
a great
have
night.
a neuroanatomy class for the visual cortex, the visual
Oh,
pathway.
yes, that's a great one. We could do maybe that's a really great one. Because then we can tie it into an emergency like optic neuritis case or like blown pupil. Yes, that's a great one.
Again, Seema, neuro-ophthalmology, my weakness.
Those are my weakness too, so I'm just using it as like an excuse to study again.
I love it. Awesome. Thanks, everybody.
See ya.
Thank you.
Thank you.
Bye. Enjoy your evening, guys.
You too.